Good afternoon, distinguished doctors, medical laboratory scientists, healthcare professionals, and everyone joining us today. It is my pleasure to warmly welcome you to today's Pinecrest Healthcare virtual webinar. Today's theme is titled Electrolyte Testing, New Thinking, New Approach. On behalf of Pinecrest Healthcare Limited and our partner, Exias Medical GmbH, thank you for taking your time to be with us today. We have an exciting lineup of experienced speakers who will share valuable insight on electrolyte testing and its impact on patient care. My name is Samuel, and I'll be your moderator for today's session. Without further ado, it is my pleasure to invite our Managing Director, Dr. Chijioke Onyia, to deliver the welcome address. Dr. Onyia, the floor is yours. Thank you.
Thank you very much, and good afternoon, ladies and gentlemen. I want to welcome all of us to this first inaugural webinar we're having on electrolyte testing, which we've captured New Thinking, New Approach. And this webinar is coming to you courtesy of the partnership between Pinecrest Healthcare Limited in Nigeria and Exias Medical GmbH in Austria. Today, we want to welcome you once again, and we want to request that you sit back because we have a bumper package for you today. There's absolutely no doubt the fact that electrolyte testing is one of the most commonly requested clinical laboratory tests, both in the small, in the medium, and in large laboratories. I don't know of any lab that exists for pathology and clinical diagnosis that does not run electrolyte testing. One can comfortably say that one of the commonly requested tests in clinical chemistry lab is a EUC, which is an abbreviation for electrolyte, urea, and creatinine. And electrolyte testing is far more than a routine laboratory investigation. It's actually a vital diagnostic tool that helps clinicians diagnose disease, assess severity, monitor treatment, and make urgent therapeutic decisions across a wide range of medical conditions. And there are several generations of technology that have passed with regards to this very important diagnostic test. Today, it's our intention to bring you up to speed with some of the new developments in the area of electrolyte testing. We have lined up for you two very eminently qualified speakers. One is a consultant chemical pathologist that has had vast years of experience, both regards to didactic teaching and also experiential learning as regards electrolyte testing in the lab. We are going to be hearing from him as he talks to us about maximizing clinical utility of electrolyte testing. We also have another very eminently qualified medical laboratory scientist of repute with several years of experience in the lab. He's going to also be talking to us about current approaches in electrolyte testing. These are very important topics that is going to help to enhance and sharpen our knowledge with respect to the new thinking and new approach as it regards to electrolyte testing. I therefore invite you to sit back, relax, and enjoy this particular webinar. I want to assure you that every second you spend in this webinar is going to worth its while. And I want to assure you that you are going to leave this webinar better than you came. On that note, I want to welcome all our speakers. I want to welcome all the participants, and we look forward to a successful webinar. Thank you very much, and sit back, relax, and enjoy the webinar. Thank you.
Thank you very much, Dr. Onyia, for those remarks. It is now my pleasure to invite Mrs. Tamara Gostimirovic, who is the Customer Support Manager from Exias Medical GmbH, to deliver her welcome remarks. Mrs. Snyder, are you there? Mrs. Tamara, are you there?
Thank you so much.
Yeah.
Good afternoon, everyone. My name is Tamara Gostimirovic, and I'm joining today on behalf of Exias Medical. So I'm here in Austria at the headquarters here in Graz for Exias Medical. And I want to thank Pinecrest for organizing this great webinar on electrolyte testing. It's a topic we are truly passionate about. So at Exias Medical, our E1 analyzer is built for electrolyte testing. And so this is very much our world. And yeah, Pinecrest has been a valued distributor partner of ours. And we are really proud of the relationship we have built together across Nigeria. And yes, events like this are a great opportunity to share new thinking in electrolyte testing. And yeah, I'm really glad to be a part of it today. And yes, I will hand it back over now, but please feel free to ask or reach out to me or to the Pinecrest team with any questions. And yes, thank you and enjoy the session.
Thank you very much, Mrs. Tamara. It was nice to have you.
Thank you.
We'll be receiving our next video message from Dr. Kenneth Inaku. Dr. Kenneth Inaku is the head of the Department of Chemical Pathology at the University of Calabar Teaching Hospital. Dr. Ken, please, are you around?
Where do now?
Can you hear me, Dr. Kenneth?
Lab. Electrolyte testing.
Dr. Kenneth, please, can you hear me? Okay, we are finding it difficult to connect to Dr. Kenneth, but moving on, we'll be moving on to the next good message, which should be coming from Dr. Okechukwu Ume. Dr. Okechukwu Ume is the head of Department Laboratory Services at the Chukwuemeka Odumegu Ojukwu University Teaching Hospital. Dr. Ume, please, are you in the building? Hello, Dr. Ume, are you there?
Oh.
It appears we are having difficulties connecting to across some of our speakers. So in just a minute, let's see how we can resolve those difficulties.
We can hear you. Oh, Abami is feeling.
Moving on, we will now move into the scientific presentations proper. Our first presentation is titled Maximizing Clinical Utility of Electrolyte Testing. And it is my pleasure to invite Dr. Lucius. Dr. Lucius, please, are you in the building?
Yes, I don't know if you can hear me.
Okay, just a minute, sir.
Can you hear me?
Yes, Dr. Imoh,
Loud and clear.
yeah.
Okay.
Just a brief
Sorry.
introduction to who Dr. Imoh is. Dr. Imoh is an associate professor and a pathologist and a medical metabolic physician at just a minute. Dr. Imoh is an associate professor, chemical pathologist, and metabolic physician at the University of Jos and Jos University Teaching Hospital. He holds an MBBS and is a fellow of the Medical College of Chemical Pathology, and he also has a Master's of Public Health. He also has a master's degree in bioinformatics and genomics, and is also a diploma and also has a diploma in medical toxicology from Cardiff. His work spans clinical chemistry, metabolic medicine, and laboratory quality improvements with numerous scholarly publications. Dr. Imoh, you are welcome, and we are so glad to have you on board, sir. So I will stop sharing my screen now so you can proceed to share your screen.
Okay, thank you very much. Let's see if I can share my screen from here. Can you see the screen?
Yes, we can see your screen, sir. We can see your screen.
Okay, sorry, I'm trying to. Okay, better. Okay, good. So, thank you very much for the opportunity to discuss this very important topic. I count it a privilege to be called upon to talk about something I'm very passionate about, which is diagnostic medicine and how we can maximize clinical laboratory testing for patient care. For this particular discussion, we're going to be focusing on electrolyte testing. Sorry, let me hide all this just a second. Okay. All right. So I'll be looking at this topic. I just want to remind us briefly about some aspects of the physiology of electrolytes, particularly in respect to the distribution and regulation. And then we'll be talking about the use of electrolytes in clinical practice. We'll be discussing that, looking at the conventional and some non-conventional testing that we very much overlook. I wanted to dwell a lot on the quality issue, but I think time may not permit us to do that so much. So, but we'll talk about that briefly, and we look at some discussion points regarding electrolyte testing in current clinical practice in our clime. So, we know that electrolytes, which always goes with the fluid in the body, account for a large proportion of any individual body weights. If you understand that the body water can be as much as 90% in neonates and as around 60% in an adult, you understand that electrolytes are also essential and crucial for metabolic and biochemical processes in the body. Just a summary of some of the things that electrolytes are critical for osmotic regulation, contractility, action potential, and nerve conduction, activation of enzyme, regulation of key important pumps in the body, acid-base metabolism, blood coagulation, and so on and so forth. So it is every aspect of biochemical and the homeostatic process in the body is the electrolytes have a key role to play in them. And we know that fluid and electrolyte imbalance is, in my opinion, one of the most common clinical conditions any doctor will face. I teach medical students this topic, and I tell them that you might be admitted for malaria and you end up with a fluid and electrolytes abnormality, and that may actually be what may kill the patient. So it is very important that doctors understand both the physiology, the pathophysiology of fluid and electrolytes, and also the testing fluid and electrolyte and how the electrolytes can be utilized. Sadly, the spectrum of electrolyte testing is quite narrow in my own clinical experience, and this is why this discussion is very timely so that we can possibly widen the scope to utilize electrolytes more in our practice. I want us to look at a few cases. We'll answer or look at the key, matters arising from these cases at a later stage of this presentation. So you have Mr. JP, who is a 68-year-old male with a chronic kidney disease presenting at the emergency department with generalized weakness and mild lower extremity edema. So when it came to the emergency department, the baseline potassium was 5.4 4 hours after he was discharged. And at home, he collapsed due to suspected
Focus on the web for when
ventricular fibrillation. And when he was brought back to the ED, testing with the main laboratory electrolyte analyzer, the potassium was found to be 6.3. You have another case of Mrs. RB, a 54-year-old female who was admitted for elective orthopedic procedure. Though she was stable, it was found that sodium level was 122 millimole per liter during a routine testing. So we were sent a consult and we observed the discrepancy between the laboratory hyponatremia and the patient's symptomatic clinical process. And further investigations were warranted. We'll talk about this later. You also have another person who was admitted for traumatic brain injury due to a road traffic accident and was administered intravenous high-dose mannitol to prevent raising intracranial pressure. 6 hours after the third dose, we noticed a sudden drop in the sodium level from 141 to 126. There was a consideration for administering hypertonic saline to correct this and also restrict fluid. Luckily, a consult was sent, and we will see what happened or what the outcome. Finally, we have a 74-year-old female was admitted for bacterial pneumonia. Was also being hydrated, with normal saline. After 3 days of admission, during routine test, was found that her sodium level was 168, chloride 135, potassium 2.9. And this was a puzzling thing to the managing physician, so because the consult was sent to the chemical pathologist. All these cases highlight, day-to-day events in the hospital. We meet this kind of things. It's very routine, in our clinical practice, just to underscore the importance of electrolyte testing in clinical practice. But for us to maximize the clinical utility of electrolyte testing, we must appreciate both the pathological and non-pathological factors that affect electrolyte testing. And we also understand the nuances of interpreting electrolyte results and also see how to, expand the spectrum of testing for electrolyte testing in different clinical conditions. Finally, it's also important to note and underscore the impact of analytical performance issues and pre-analytical conditions or considerations that affect electrolyte results. So if we look at the distribution of electrolytes, predominantly they are into cations and anions. You have some that are predominantly in the extracellular fluid and those in the extracellular fluid, intracellular fluid, all right? So you have this category, the predominant cations in the extracellular fluid, especially sodium, while potassium predominates in the intracellular fluid. This will be a routine thing for any medical student and practicing clinician. So it's important to understand this distribution because that will help in the interpretation of electrolyte abnormalities. Looking at the regulation, we know that there are some organs that are key, especially the hypothalamus, the pituitary, and the adrenal. There are other organs that also play a role. There are several hormones that are involved in the regulation of fluid and electrolytes, especially the antidiuretic hormones, aldosterone, and atrial natriuretic peptides. Some sensors, including osmoreceptors, test centers, and bioreceptors, are key in this regulation. And the stimuli for this regulation include osmolality, thirst, and blood volume, which are all related. So let's look at some of the common indications for electrolyte testing in our environment that we know. One is to estimate osmolality. The other is to evaluate, electrolyte imbalance, especially hypo, kalemia, and natremia. Okay. And lastly, is also to assess acid-base disorders. There are some other tests situations where they could be indicated, especially urine electrolytes, okay, and also assessing urine osmolar gap, the gap-to-gap ratio, fractional excretion of electrolytes, and some other key calculations or computations that can be used, in managing patients. Talk about this. So when we look at estimating osmolality and the importance of osmolar gap, we see that electrolyte is key in this assessment. By definition, osmolality, of course, is the amount of solute per unit solvent. That's the weight per the weight per width measurements, okay, as opposed to the osmolality, which is the amount of solute per unit solution, okay, and it's like a weight per volume, right? So in practice, they approximate. However, the difference is that osmolality is a colligative property, so it can be measured, and it is actually the stimuli that that determines regulation of fluid and electrolytes distribution in the body. Whereas osmolality is not a colligative property, it's not measured. However, we can calculate it to try to estimate the osmolality. So in normal patients or normal circumstances, these two approximate, okay? There are several formulas for calculating osmolality, or this is perhaps the most common, using very common analytes that we use day to day. So when you, in the normal time situation, you find that there's a slight difference between the osmolality and the calculated osmolarity, which is now approximated as osmolarity. So that small difference accounts for those osmotically active particles which are not measured, or which are not involved, in the calculation that you have here. So you only have sodium, potassium, urea, and chloride, and glucose. You don't have so many of those osmotically active particles. So as opposed to the osmolarity, which will measure all those particles. So this gap is what is called osmolar gap, and you can use it in the assessing of fluid and electrolyte, and even in acid-base homeostasis. Okay, so osmolar gap is increased where you have those osmotically active particles like diabetic ketoacidosis, alcohol, lactic acidosis, methanol poisoning, and so on. And in situations of hyperlipidemia and hyperproteinemia, right? So you find that that gap becomes wider, right? So it's also important to note that sodium is the main factor in the calculated osmolarity, which accounting for more than 90% of the calculations. As you can see here, if you multiply this, it's more than 90% of the calculated osmolarity. So sodium is very, very key, and therefore the direction of sodium will affect the direction of the osmolarity. Okay. Just as I said earlier, while we calculate this, you can see that you need electrolytes to calculate this. And so if you don't measure electrolyte, many times we do not calculate this. We just repeat or interpret sodium, potassium, chloride, and that we go our way. Most times we don't pay attention to this computation. And I'm here to say that it's important that we pay attention because they will help us interpret the fluid and electrolyte abnormality. We also know about the electrolyte exclusion effect. We not go too much into this. Basically, we just talked about the fact that the electrolytes are in the aqueous space, and so about 70% is said to be the solid part of it, which has been factored in the calculations or in the measurements of electrolytes using ISC, both direct and indirect. However, in the situation where you have increased solid phase like hyperproteinemia, hyperlipidemia, you are narrowing down the aqueous phase. So when you take a sample that is going to be diluted, you take a sample, you have taken a lower amount, of the constituent of the analyte in question, in this case, sodium, to analyze. And so you see that you have a falsely reduced sodium that is measured. The ISC actually measured the correct sodium in that was given to it, but your interpretation is lower because you have taken a smaller fraction and you are using is a pre-diluted specimen. And so you only observe this when you have flame photometry or indirect ISC. Somebody is writing on the screen and maybe the person should stop. So this becomes important because of the analytical differences in different platforms. Up till now, some people still use flame emission spectrometry and indirect ISE in some analyzers, while some centers or platforms use direct ISE. And if we don't understand the difference, we may not be able to interpret our electrolytes, particularly sodium, correctly. I also want to highlight the importance of correcting sodium in the interpretation of sodium assays. So whenever you have hyponatremia, the first thing that is necessary or is important is to assess the osmolality, and that is to calculate, to be able to classify your hyponatremia into hyperosmolar or a hypoosmolar hyponatremia. When this is done, the pathways to the assessment becomes clearer because when you have an hyperosmolar hyponatremia, it's actually not a true hyponatremia, but it is an artificial diluting, because of the hyposmolarity, it draws water into the ECL and dilutes the sodium, right? And this is important because if you don't understand this and you begin to treat the supposed hyponatremia, you might cause more problems, as we will see later. Also, there may be need to correct for the sodium in this situation. It's just that because you have so many things that could cause hyperosmolality, it's difficult to be able to get, a regression analysis and get a formula to calculate that. But in the case of specific conditions like hyperglycemia, right, it has been calculated, and there are several ways that you can use to correct. So you have the traditional CATS formula, in which you add 1.6 to every 100 milligram per DL rise above 100 milligram per DL. So that's the formula there. So once you get the glucose in milligram per DL, subtract 100 from it, divide by 100, whatever you get, you multiply by 1.6, and you add that. You also have the updated HELAS formula, but perhaps the more simplified one that can be easy for everybody. This is usually in millimole per liter. Just divide the sodium by the glucose by 4, and then add to the measured sodium, and you can correct. So I'm saying that we should watch out for hyperosmolar hypoglycemia because you have a lot of diabetes, you have diabetic ketoacidosis. So when you see hyponatremia, watch out for hyperosmolality, and if that is due to glucose, make sure you correct before you interpret. It's also important to know that some formulas or some analyzers incorporate this into their calculation. So there's a reflex calculation or correction of sodium. So if you have such an analyzer, you can institute it where once the analyzer has a glucose result, it can correct for the hyponatremia. So this is a flow chart of just explaining what I've said, categorizing hyponatremia into hyper and hypo. So the first thing you do when you have hyponatremia is to first of all check for the hyperosmolality, for osmolarity. Once it is hyper, that is easy to sort out to find the cause of the dilutional hyponatremia. But if it is hypo, then that's when you now begin to go into the other assessment, which we'll talk about later. Another thing that you can use electrolyte for is anion gap. Again, many of us already know what anion gap represents. It's used mainly in the context of metabolic acidosis, right? Just because we have a mixed or a mosaic of listeners to this program, I'm just explaining that anion gap is used in the context of metabolic acidosis. So once you have determined that there's metabolic acidosis, of which the hallmark is low bicarbonate, then you go ahead to calculate your anion gap. So patients in the ICU should have this calculated for every time you have the electrolytes, right? Of course, you can see that it is difficult to do that when you don't have bicarbonates, and many centers don't even do bicarbonate assays, and that's for a fact. So you can use any of the formulas, some add potassium, some remove potassium. So whichever you use, the reference range is there for you. So when you have a high anion gap, of course, it talks about presence of some metabolically active substance that's donate their hydrogen ion. So you have different mnemonics for that: Dr. Maples, Mopies, and so on and so forth. Then you have a normal anion gap, also called hyperchloremic metabolic acidosis. Here, the anion gap is normal, okay? And you can have several conditions relating to GI abnormalities like diarrhea, fistulas. You can have things like parenteral nutrition, Addison's disease, and so on and so forth. So it's important to assess for either high or normal anion gap in the context of metabolic acidosis. Then we'll go to the gap-to-gap ratio, which is something that most times we don't do. So you have an electrolyte, you can go ahead to calculate the gap-to-gap ratio, particularly when you have a high anion gap metabolic acidosis. Now, there is always compensation, and sometimes you can have a mixed acidosis, right, for patients. So you want to use this to know whether you're having a pure high anion gap metabolic acidosis or whether it's a mixed anion gap metabolic acidosis. That's or there's some compensation going on, or there's a concurrent non-anion gap metabolic acidosis. So the picture can be confusing for those who work in emergency centers. So you use the gap-to-gap ratio to assess that. Basically, it checks whether the change in the anion gap that you're seeing from normal is equivalent to the change in the bicarbonate from normal as well. So the difference from the normal, the anion gap, and the difference of the bicarbonate from the measured bicarbonate, they should approximate. But if they don't, then there is a problem somewhere. Just to make the formula simple, so you have the normal anion gap has been estimated or assumed to be 12. So you have anion gap minus 12, and then you have the bicarbonate level has been assumed to be 24. So you have this. So once you use the simplified formula and you have a ratio that is 1, okay, that means what you're dealing with is an isolated high anion gap metabolic acidosis. If it is less than 1, then you have a normal anion gap, so it's a mixed disorder. And if that ratio is more than 1, then you probably have a metabolic acidosis coexisting with a metabolic alkalosis. Now, why this is important, ladies and gentlemen, is, for example, in diabetic ketoacidosis, you have an ongoing metabolic acidosis due to diabetic ketosis that is ongoing. But you know that treatment, one of the key parts of the treatment is isotonic normal and fluid infusion. And so we know that fluid infusion can also cause, the normal anion gap metabolic acidosis. So that can give you a confusing picture, and this will help you sort out and clarify what's going on. So you have glucose to plasma ratio. That's another ratio you can pay attention to. that can just give us an indication to the neuroendocrine response, particularly in the context of acute and critical conditions. So there is no agreed cutoff, but it has been shown to correlate with the prognosis and severity of high mortality rates and increased complications in some conditions like traumatic brain injury, subarachnoid hemorrhage, and in very critically ill patients, and also in acute stroke patients. So it's another thing we can look at when we manage patients. The urine electrolytes is largely overlooked in clinical practice, but it's very, very informative, right? So these are some of the non-conventional things apart from the other ones I've mentioned. So we need to pay attention to that. And you can use urine sodium to evaluate hypovolemia, renal impairment, and so many other conditions. But most commonly, it's used to classify acute kidney injuries. What is causing is a pre-renal or an intrinsic kidney dysfunction. And you can also use it to classify hypoosmolar hyponatremia. So when you can have hypoosmolar hyponatremia, you can classify them into any of these three. That is hypovolemic, hypervolemic, hypovolemic, or is even euvolemic. And so when the urine sodium is high or low, that tells you something, because the basis is that when you have a hypovolemia, the kidney is supposed to compensate or react by reabsorbing a lot of sodium, and that will cause a reduced amount of sodium in the urine. So if that is not happening, that can tell you that whether this is this hypovolemia is caused by renal cause or not. If it is from a non-renal cause, that means the kidney is functioning. So in the setting of hypovolemic hyponatremia, you find that the kidney will be able to the kidney will be able to reabsorb a lot of sodium. So you have low sodium in the body. So you have that when you have the non-renal causes of hypovolemic hyponatremia. But when it is from the kidneys, you're going to lose a lot of sodium, which you're not supposed to, because if the kidney is working well, or if there is no other force causing loss of sodium like diuretics. So these algorithms will tell you what is going on. And because of time, we'll have to skip and not go too much into details. Assessing renal function, when you have a pre-renal acute kidney injury, in an attempt to conserve the sodium because of the reduced blood volume, supposedly you have reabsorption of sodium, so the urine sodium will be very low. But if the urine sodium is high, that suggests that this acute kidney is intrinsic to the kidneys, and maybe there's an acute tubular necrosis. Because of the variation, day-to-day variation, diurnal variation of sodium, which is usually high in the day and low in the night, for example, you might want to compensate by using a fractional excretion of sodium. And so the concept of fractional excretion of electrolyte is very important because you are compensating, with the more stable analytes that's like creatinine. So it's more like the GFR, the clearance of the analytes consign versus the clearance of creatinine, and that can be used to correct for those variations. So if it's high, you're saying that the body is excreting that substance in a higher amount than usual. And if it is low, it is excreting it in a lower amount than usual, right? So when you do the clearance of sodium over the clearance of creatinine, you inverse this and you find this formula. And that runs true for every analyte you're dealing with, whether it's fractional excretion of bicarbonate, fractional excretion of calcium, and so on, fractional excretion of phosphate, and so on and so forth. So in the case of acute kidney injury, When it's less than 1, suggesting that there is poor excretion of sodium, which suggests, retention of sodium in prerenal azotemia. And if it's greater than 1, it is speaking more of an acute tubular necrosis. The drawback of using urine sodium, like I said, is that it can be affected by daily intake, diurnal variation. In the case of diuretic use, that might confound the picture. So in that setting, you can use fractional excretion of urea to assess this. Urinary potassium is usually used in assessing hypokalemia. So you can use spot potassium, right? If the potassium in the urine is low, okay, you're suggesting that this is a GI cause, okay? But if it is high, that means it is a renal cause because the renals are supposed to reabsorb this potassium. So the sodium potassium ratio is another biomarker that can be used not only for assessing endocrine functions, particularly things like aldosteronism and so on, but it can also give you an indication of the risk to cardiovascular health and even the kidney health, and also the lifestyle, the dietary lifestyle. So ideally, you should have a lower ratio, suggesting that you're taking more potassium-rich substance versus sodium, right? So once this ratio is high, it's suggesting higher risk of cardiovascular disease. Then you have another computation from urine, which is the urine anion gap, just like we have the anion gap in serum. But in this case, the urine anion gap is specifically used for the assessment of non-anion gap metabolic acidosis. So we see that largely the main causes are both either renal or gastrointestinal causes, right? And the basis for this is that the kidneys, in response to low bicarbonates, which is the hallmark of metabolic acidosis, okay, reclaims bicarbonate and excretes hydrogen ion. This hydrogen ion, binds with ammonia, so you have ammonium chloride, right? So you're actually assessing ammonium, but we don't measure ammonium, so we measure the compound that's bound to it, which is chloride. So if there is a proper response, you should be excreting a lot of ammonium chloride, right? Suggesting that this is not coming from the kidneys because the kidneys are functioning by excreting ammonium ion. But if it is from the kidneys, they will not be able to excrete this, right? So if you look at this, and this gap is, negative, meaning that you are excreting a lot of chloride, and that means the kidney is functioning well. So you can say that this problem is from the GI. But if it is from the kidneys, you are not able to excrete hydrogen ion, or, as you find in renal tubular acidosis, and so you find that the anion will be low, and you have a positive urine anion gap, and this will suggest that this is a renal cause. So this can just be used. So we can do all this from time to time. And they are very simple things that we can do in urine. So I'm just highlighting that in our day-to-day use of electrolyte, there are many things we can use electrolyte for, which we are not using it for. And you also have fractional excretion of bicarbonates, okay, to assess tubular function, particularly proximal tubular dysfunction, okay. Because of time, I have to run. You also have fractional excretion of calcium. Let me just skip this and go to ionized calcium, which is another luxury we have from electrolyte analyzers. Modern electrolyte analyzers can also analyze ionized calcium. So there's a debate between ionized calcium versus albumin adjusted total calcium, right? We know the relationship that 50% of the calcium is free or ionized, and there's a debate of which one to measure. What is clear is that albumin corrected formulas are highly inaccurate because you have a generalization of the use of correction formulas taken from regression analysis from another culture or environment or population is forced on us. And so what you have is false positive and false negatives in the setting of hypercalcemia and hypocalcemia respectively. Okay, so and up till now, many institutions still defer to total calcium panel. So what is the debate? You find that the ionized calcium actually gives you the biologically active substance, right? And in the setting of illnesses, okay, it's supposedly highly accurate, as opposed to the adjusted calcium, which are affected by the albumin levels in disease condition like liver and chloride and kidney disease. Okay, and when you have acute illnesses, particularly people in ICU and so on, where you have acid-base abnormalities, the ionized calcium level shifts. When you have acid-base abnormalities, in alkalosis it drops, in acidosis it rises, but you may not see this in the adjusted calcium, in the adjusted albumin adjusted to calcium. Okay. But another drawback, the drawback for the ionized calcium is that it needs a very strict measurement. Okay. And that's one of the things we need to consider for those of us who use the ISEs that have ionized calcium. It has to be an anaerobic conditions because of pH changes of the environmental conditions. But the total calcium does not need any of some of these strict regulations and can easily be automated. So that's why many centers still use the total calcium. And of course, you can know up till now, some centers don't even have the ISEs to measure ionized calcium. So the debate is there. There's this issue of cost effectiveness, issue of availability. But and so the debate goes on about whether to treat with ionized calcium or not. So the people are saying, yes, the ionized calcium reflects what is going on, what is changing, and can be used to optimize cardiac function and prevent abnormalities. But the skeptic will tell you that these slight changes may not be enough to cause problem. And when you start treating, you might have worsened, the problem. So the debate is ongoing. However, there's a consensus, which I think should be the take-home, right? For if you are assessing patients, from outpatients, you're doing a screening, routine exam, you might settle for the total calcium test because it's cheap. It can be the first liner test. And if you're in doubt, you can go for the ionized calcium. So majority of our patients will fall in these categories. However, for those in the ICU or those in the acutely ill, those with chronic kidney disease, you might go for the ionized calcium measurement. That is what current guidelines like the ADLM are recommending currently. I also want to mention, keep a space for CSF chloride, which I have found that in many centers it's not done when you do CSF analysis. But I once practiced in South Africa for a while, and I noticed they do this a lot because they have a lot of HIV cases and tuberculosis, meningitis, and so on. So it is low in the case of bacterial meningitis, right? Whereas in other viral meningitis, the levels might not be that low. So that could be another guide, to what's going on. Maybe I should just talk a bit about some pre-analytical. That if you want to get the best, because I'm coming to the end of this presentation, if you want to get to the best of electrolyte assays, you must pay attention to the pre-analytical conditions. Okay, the kind of sample tubes, these are some basic things that we need to pay attention. Specimen tubes that are, for collection. Are you taking plasma or serum? In the case of plasma, you may want to go for a lithium, heparin, tube. Okay. We also have to pay attention to the issue of interference, especially hemolysis, particularly in the case of potassium, lipidemia in the case of sodium, as we highlighted earlier. We also need to pay attention to collections, like urine collections, we don't want to use any additive as much as possible. In any case, most of the collections are actually sports collections. Biological variations are also important, but have been shown not to affect too much of the interpretation of these analytes. Okay, so it's important to take note of this. Also, the separation of the sample. Sometimes you may not see anything, you may not see hemolysis, but the potassium is erroneously wrong because of how it was handled. It has either was transported and separated for late, in which case you have so many of the intracellular potassium, spilling over into the separated serum, and you will have no indication whatsoever. So we see those spurious hyperkalemia, and sometimes clinicians don't understand the relationship between the sample collected and there's the delay in getting to the lab or the delay in separation. Sometimes even those us in the lab, we also don't pay attention to the fact that you need to separate U and E samples on time. And also particularly when you have to measure biocarbonates, you have to be wary of the environmental conditions. So you need to separate them quickly and analyze them quickly. Now, the impact of these little pre-analytical considerations goes a long way, because sometimes if, for example, you're not aware that this separated late, you might get hyperkalemia and you begin to correct, and actually it's a spurious hyperkalemia. So there are a lot of pre-analytical issues. Also, you talk about issues of maybe things like leukemia. When the patient has leukemia, the impact on potassium levels and so on. So many pre-analytical conditions to prevent. So it's important that we pay attention to the pre-analytical condition. Equally important are the analytical performance. Not all systems are the same, right? And so you find that for electrolyte assays, a lot of things I'm saying now are related to my experience, personal experience. It's one assay that can drift, very quickly. So labs should pay attention to the precision and the accuracy, particularly using EQA specimen to note the difference between the expected value and the mean value that you are getting for a particular control level. Now, these bias and precisions are important in the laboratory total allowable error, right? And which is important, your allowable error is important in your interpretation, because if it's a narrowed, if your CV and your bias is very narrow, your allowable error will be narrow, and so you'll be able to dictate abnormalities. Okay, this has consequence for things like reference change values and so on. But if it is so wide, because the CV is wide, the bias is wide as a result of the equipment, as a result of the reagent, as a result of so many other factors, analytical factors, then the uncertainty in your measurement will be so high, and at the end of the day, you may not be able to tell whether a patient is improving or deteriorating, particularly in the context of monitoring patients. So we also pay attention to the issues of electrode deterioration and reagent deterioration, which is very common in electrolyte assays, particularly ISEs, higher selective electrodes. Many labs still don't do internal quality control. And I also found out that even those who do not chart. So doing an internal quality control is not enough to say this is within control. You need to chart and get, your Levigenis chart, for example, to guide you in your decisions, and how to keep your quality specifications very, very tight. I cannot overemphasize the importance of external quality control, for our electrolytes. Luckily, we have where I practice on my center, we have, we participate in an internal quality control proficiency testing, and the electrolytes have been one of our success stories. We had challenges in some of the analytes, but electrolytes have so far been very good. So let me pivot now to the issue of the suboptimal use of this biomarker. You can see that there are so many things we can use in our daily practice, but how many of them do we use apart from, just reporting that the electrolyte values, hyponatremia, hypernatremia? How many times do we assess? How many times do we use even these electrolytes to go further? So you can see the narrow testing spectrum that we have. And this is quite a worry, for us, particularly in this 21st century healthcare as a setting or ecosystem, where you need, to be much more efficient in managing patients, right? So some of the things I have discovered that could be responsible for this is the fact that sometimes you could have insufficient local data, on outcome studies, particularly for some of these biomarkers. And sometimes, or more importantly, the clinicians will complain of availability. Sometimes they will say the tests are, expensive. Sometimes there's the issue of the know-how. They may not be able to know how to use this, which is where, as laboratory practitioners, we should have a handshake, with our clinical counterparts to say this is available. Our electrolyte machine can actually do urine assays, right? Sometimes, I remember one of a cardiologist, calling to ask for urine assay. Is it possible to do? And, when I told him it's possible, since then we've had a couple of requests from him. So sometimes they may not be aware. And again, we also know that, old habits die hard. So we have to do a lot of engagement with our clinical colleagues to let them know the importance and the utility of this, and which is why this webinar is very, very important. So when we don't use these markers, it robs us of the experience that we need and also the impact on disease, the management of disease. Another issue that I also want to point out is the issue of the different platforms that we use. Up till now, we still have so many platforms, and many patients think that all the results from labs are the same, but they are not the same. So it's about time we begin to look into the issue of standardization of this, because you can have different platforms. So what is the relationship about these platforms? For example, in electrolytes, you can even do electrolyte with atomic absorption spectrometry, flame emission spectrometry, ISCs, which are quite common now. But even in the IC, you have the direct and indirect. And then some people still use photometric methods, using chemical methods, right? So how are these results? So a patient is monitoring in different labs and we are having this problem. So we will have to look at all this. Now, also you have so many systems coming in. Have they been really verified, in our setting? What's the diagnostic performance characteristics, in our setting? So we need to pay attention to this. Let me round up this presentation by looking at those cases. Remember the case one where we have electrolytes results 5.4 and later came back and it was 6.3. Later, we found out that the emergency department electrolyte analyzer had developed a progressive negative analytical bias of 0.8 at the higher control level. And this was due to a degrading reference electrode, right? So you have electrode problems in some of these analyzers. But the QC, had been running at an acceptable level. Again, that's where how tight is your control in your own lab. So you see, if it is wide enough, then you can miss out some important things, right? So you can see that the values they were getting were within their total allowable error, and so their system did not flag this bias, and it reported consistently lower values, about 0.8 lower than what it was when it was done in another lab. You had the correct value 6.2, which was responsible for the patient's conditions and requiring that this patient needed to be stabilized. So this brings to fore the issue of ISE electrodegradation and the issue of the, performance, the performance of your systems. Have you studied the performance of your systems? What are the mechanisms put in place to make sure this is tight? For the second case, where an elective patient just suddenly had a drop in, you had the sodium that was low. It was found that they used an indirect ISE method, okay, and other results that became available showed that the patient had a, hypertriglyceridemia, and you can see the impact of the electrolyte exclusion effect in this. So when you did it with the direct ISE, you had the correct result. So this also brings to fore the importance of the method and how we need to communicate this with our physicians, and also the need for automated or reflex testing. So in many systems, as you're measuring electrolyte, you're also measuring for some interferences like the HEAL index, the hemolysis ectoris lipidemia indexes, which can trigger, a reflex adjustment. Maybe for some, they may need to be diluted and repeated, also it may be flagged and repeated with another system that is not affected by that kind of interference. So this is very, very important. For the third case, the patient was given mannitol and was found to have a drop in the sodium level. It was found that after the consult, the osmolality measurements showed that there was hyperosmolality. So, of course, this is a case of hyperosmolar hyponatremia. It's not a true hyponatremia. So, the good thing is that it was flagged on time. If they had gone on to give the hypertonic saline, or it would have caused more problem, because you will cause cerebral cooling and death. So this is very, very important. Okay, it would have caused more injuries. So it brings to fore the issue of measuring osmolality. If our ISEs, I just want to mention for those vendors here, please look at getting osmolality. There are no osmometers in many centers, and you cannot manage fluid and electrolytes without an osmometer. So it's important to incorporate it into the ISE. I don't think it will be too difficult, even though, yes, many of them use freezing point depression method, but it can be done, right? Or they can be sold or made available. It's important, for example, for every teaching hospital to have an osmometer, right? So in this case, the patient was the mannitol was stopped and the patient was observed till they excreted, the free water, okay? So it's important to measure osmolarity. It's also important, the importance of collaboration, like I mentioned, between the clinician and the laboratory managing that is producing the result. Very important. This handshake is important if our patient will survive fluid and electrolytes indeed. And also the importance of corrected sodium, which I highlighted, especially in the setting of hyperglycemia. And you can also automate this so that you get the correct results and you don't miss out this correction. Finally, for the last patient, who was a patient with pneumonia and was on IV fluid, normal saline, with a drop of high sodium value, high chloride value, low potassium. The consults, investigation showed that this was obtained from a drip arm. All right, it's a classical syndrome. When you see high sodium, high chloride, and you see low potassium, it's a classical feature of intravenous contamination. Okay, and so if you take a repeat, you may get a good result. So it's important to note that even pre-analytic conditions can cause this. So don't be weary of asking for a fresh sample if things are not, very clear. And also the need to have delta rules, where if you have a patient's value, particularly some people have been on admission and you see a sudden jump, it should trigger further investigations. All right. And also to recognize these patterns or these footprints that have, for example, high sodium, high chloride, and low this potassium. All right, thank you very much. I want to conclude now by saying that electrolyte testing is actually a pivotal part of clinical care, using to optimize patient care. And also, even though we find that there is a suboptimal utilization of electrolyte testing, there are opportunities, and there's just for us to get to know them and also have this handshake with our clinical colleagues. The importance of collaboration was also highlighted, bringing to fore the importance of the pre-analytical and analytical performance. We need to be able to do this from the lab and also communicate this expanded spectrum and be involved in result interpretation and troubleshooting fluid and electrolytes abnormalities. I want to thank you so much for your kind attention, and I'll be happy to take questions, contributions, and comments. Thank you. Over to you.
Thank you very much, Dr. Imoh, for that very detailed and insightful presentation. In fact, your presentation has reminded us that electrolyte testing goes beyond producing laboratory values, as it plays a very critical role in timely clinical decisions. So thank you very much for your expertise. We really appreciate your time, sir. Thank you very much once again.
Thank you. Let me stop sharing now.
So moving on, we're having our goodwill message from Dr. Kenneth Inaku. Dr. Kenneth Inaku is the head of Department Chemical Pathology at the University of Calabar Teaching Hospital. Dr. Kenneth, are you in the house?
Yes, good afternoon, everyone. And
Good afternoon, sir.
thank you, Lucius, for that very informative presentation. I want to also thank the company, Pinecrest Limited, for putting this together. All right. Okay. I hope I can be heard.
Yes, you can hear you now, sir.
Yes, please. So I want to thank Pinecrest Limited for putting this together, and I think they have provided a very good solution to our electrolyte problem with the Exias machine. When I took over as head of department about 2 years ago, I met a very huge electrolyte problem on ground. We're using a method of still ISC, but this had to do with replacing electrodes. I'll not call any brand here so that I don't demarket anyone. But then, as a resident in Jos, I had used a machine where we change the snapback every time the content is exhausted, and we didn't have issues with getting electrodes, which was not easy to come by. So before I came on board, for 3 months, a whole lab had not done electrolytes. And I said this was a problem. So I started making calls. I called Jos. Do you still have this machine that is snapback? They said, oh, no, they're not using that again. I called another state. I called Lagos. Then they said, no, they didn't have it. I said, what do I do? But I need this machine. And as God will have it, it was like a miracle. Somebody just knocked my door. That same, about 30 minutes after I finished speaking with a few persons. Somebody knocked my door and then gave me a leaflet that this is an electrical machine, that you don't need to buy electrodes, you just need to change the cassettes. And I just held myself. I didn't need to show him how excited I was so that he would not give me a price that I can't pay. So I just controlled myself and I told him, well, this is what I was looking for. Immediately, I took him to my CMD. I told my CMD I have solved the electrolyte problem. Let us sign this agreement immediately, and we will never have electrolyte problem. The CMD saw my enthusiasm, saw my conviction, and didn't argue a bit. He just said, where is the MOU? It was produced, we signed immediately, and the machine was placed. And since then, true to what I envisaged, true to what I told my CMD, we have been giving out electoral results without any hitch. So I want to thank Pinecrest very well for bringing this in and making life very easy. Because sometimes with the other machine, we're waiting for 3 months for electrodes to come. Imagine not providing electrolyte in a teaching hospital for 3 months. That was loss of revenue and everything. So it has been a big solution, and I would recommend it to any center. We've been getting quality control from them, and it has been passing. So I will want to recommend the Exias ISE to anyone who wants a solution to their electrolyte problems. Thank you very much.
Thank you very much, Dr. Ken, for giving us this beautiful message. So moving on, our next speaker is MLS Jude Kamah. MLS Jude, please, are you in the house? MLS Jude, can you hear me? Hello, MLS Jude, are you with us? So while MLS Jude is sharing his screen, let me just quickly introduce him. So MLS Jude is the Deputy Director of the Medical Laboratory Service at Enugu State University Teaching Hospital. He obtained his Bachelor of Medical Laboratory Science degree from Ambrose Ali University in 2003 and has built a very impressive career spanning both the private and public healthcare sectors. He holds a master's degree in chemical pathology and is currently pursuing a PhD in clinical biochemistry. He is also a lecturer, researcher, and author with several scholarly publications and has presented at numerous seminars and workshops. And today he will be taking us on current approaches to electrolyte testing. So, MLS Kamah, the floor is yours.
Thank you. I want to share screen.
Okay, while we are waiting for the slides to come up, please, I would also like to repeat this. If you have any questions, you can please drop these questions in the chat box, and during the question and answer section, we are definitely going to take a look at it and answer your questions.
Sorry, I'm having some problems here. Want to Problem sharing screen.
Okay, sir. Should I assist in sharing from my end?
Can you do that?
Yes, I can do that.
Please. The network itself
Okay.
is having some hitches here.
Okay then.
As we are waiting for the slide, please, because of our time, I want to appreciate Dr. Lucius for the scholarly presentation, very in-depth analysis of electrolyte testing. He has discussed in-depthly on the clinical applications and the pathophysiological aspect of electrolyte testing. I equally want to apologize that this is a narrow area that is going to be overlap, and Dr. Imoh had discussed majorly all aspects of electrolyte testing, surprisingly briefly aspects of quality assurance and performance of the testing. Now, we are going to discuss on some of the analytical aspects. As laboratorians, want to look at aspects of testing for electrolytes. We know that this has always been a challenge, as Dr. Imoh has mentioned. Please, let's look at the first slide. So in the context of our clinical laboratory testing, we want to discuss this aspect. This is briefly the context of discussion, introduction to electrolyte testing, conventional laboratory methods, challenges, future directions, summary, and conclusion. This is more of a miniatural discussion on the analytical aspects of the testing. Now, what are electrolytes? The first discussant has dwelled in-depthly on the utilities of electrolytes. The electrolytes function as conductors of electrical impulses in muscles, muscle contraction, nerve transmission, control of blood pressure through the renal mechanisms, and of course, looking at the electrolytes as controlling osmotic pressure. He has very much discussed on that. And the compartmentalization of the electrolytes of interest, sodium being the principal cation of the ECF and the potassium of ICF. Incidentally, he mentioned the analytical variables that can impact on the concentrations of these electrolytes through sample handling, sample preparation, and even during the actual testing, as occasioned by different methodologies employed by the testing modules, whether they are auto-analyzers or standalone ion selective electrodes. In fact, it has been said that without electrolytes in their charge state, that's not an overstatement. So we can in clinical investigation, just as we see the fourth clinical care in our healthcare system. The next slide, please. So as a matter of by convention, we want to highlight three major testing methods in the environment, because we know that some centers still use flame photometry, even though it has been abandoned largely because of inherent problems associated with it. Ion selective electrode is the tech of today, and auto-analyzers are found commonplace in most clinical laboratories. So we want to briefly look at the historical evolution or unfolding of blood electrolyte testing. Before now, in the 1800s to 1930s, that is almost far into the 19th century, we saw the advent of wet chemistry era using gravimetric and tachymetric methods. Some of us, when we trained as students, we were exposed to the method of scarless and scarless for quantitation of serum chloride, yes, in which chloride was precipitated as sodium chloride. And we were educated by that method. But these methods have been abandoned because most times these methods take days to hours to produce a result. And then some of the reagents used were actually toxic. So because of the hazard associated with them, they have been abandoned. So from there, 1930s to 50s, the advent of flame photometry, and it was a time of excitement because sodium and potassium could be quantitated directly on serum samples sprayed as aerosols on a very hot flame made up of propane gas. And the emission of these elements as they are excited were measured as they return to the ground state, emitting discrete packets of energy that are actually captured through monochromacy and then converted to electrical signals, which are read through either galvanometric or digital readout. So this method was a method of choice then, but then due to problems of interferences as a result of dilutions and other ions in solution, and then exposure to flame hazard. Of course, the large volume of sample that were required to run flame photometry, this method was not something that was amenable for pediatric population where we need to have a micro sampling. So this was subsequently abandoned. Even though regrettably in our environment today, we still use this method in some centers. It sounds absurd, but that is true. Then from 50s to 70s came the advent of the ion selective electrode, the membrane electrodes in their different forms, the sodium glass electrode, and then we have the potassium vanillomycin polyvinyl chloride electrodes. They have chloride electrodes. And of course, these came with a reference electrode through which they were compared. And the principle is basically the measurement of potential difference across the different selective membranes, which are selective and specific for the ion of interest, whereby the potential difference between the membrane and the sample solution interface are proportional to the logarithm of the activities or concentrations of those electrolytes as computed from the next equation. Today, the electrodes are still the tech. You find it in many analyzers, point of cares. It is still the electrodes in their different forms, including miniaturized forms. Then 70s to 90s came the time of automation. We have big laboratory analyzers housing indirect ISC and then direct ISC. Of course, indirect ISC, as Dr. Lucius has mentioned, has its own limitations and gains. This has to do with sample dilution. Sample has to be diluted 1 in 20 most times, because more volumes of samples has to be diluted in large enough volume to be presented to the electrode. This will prevent coating by protein, assuming the samples were not diluted. But then this introduces electrolyte exclusion effect in cases where we have pathophysiology that changes the sample metrics, now deranging the 93% plasma water and 7% solute for electrolyte composition and solutes respectively. So this becomes a shortcoming. Of course, the direct electrons were built into point-of-care testing devices that we have today. Then 80s to 2000, there's an overlap while the automated systems are still in place up to today. The blood gas analyzers, particular blood gases, were evolved with a point-of-care testings. And these housed mini ISC cartridges. You find them in arterial blood gas analyzers and some handheld meters. And then within 2000s to 2006, that is today, came the advent of the microfluidics, the sensors and integration. The microfluidics actually are devices made up of channels, sensors, and then it incorporates valves, whereby reagents mixes with samples, micro samples, and they are moved to the sensors for measurement, and then results appear in a matter of minutes. Of course, the integration there has to do with bringing all these parts into one separate entity. That is the microfluidics, the sensors, the chambers, the valves. Of course, you have the calibrators, you have the wastes, you have the QC, all in one, and they're integrated into cassettes or modules for testing. And that is where we find ourselves today, and that is the innovation of today. Next slide. Then auto analyzer modules. Most laboratories have auto analyzers of various capacities, and these ISC electrodes have been integrated into these large chemistry analyzers as indirect electrodes in other formats, some as direct electrodes. Of course, these analyzers have the advantage of handling high throughput of samples. So in centers where you have large batches of samples coming in on a daily basis, these are the analyzers of choice. And they are automated, meaning that very minimal manual interventions are necessary in the operation. We have said that they are used in central labs and they require large patient volume. So small laboratories cannot key into most of these auto analyzers because of problems of expiration of reagents, as they have large batches of samples to deal with. Next slide, please. So the next is the standalone analyzers. These house ion selective electrodes, which are direct electrodes. Some of them, most of them are compact, which means you can move them around, and that is why you find them various sites in the hospital. See them in the ICU, intensive care units, the emergency rooms. Even some of them are found in a very busy clinician office. And then they are all used for critical care. And they give out electrolyte results in a matter of minutes. Sodium potassium chloride, as have been discussed by the first presenter, calcium, ionized calcium, and the pH are all given. In some of the modules, you have a calculated bicarbonate, which of course have some inherent shortcomings because these are calculated parameters, and sample handling from separations to the duration of keeping of the samples, as Dr. Lucius mentioned, can actually affect that factor that have been imputed in the analyzer. And in most times, you find out that they are out of control. The results are not reliable. And that becomes a major problem in using the calculated values for bicarbonate in some of these standalone analyzers. Next slide, please. So we said, are there challenges? We have been mentioning some of them, but let's look closely at some of them, taking a closer look at auto analyzers modules. The inter-analyzer variability. Sodium is always the culprit as a major cation of the ECF. You find out that from one platform to another, from one vendor to another, auto analyzers show some variability in sodium results that are produced. And then what are the causes of this variability? Of course, there may be 4 drivers that could be mentioned. First of all, could be the electrode itself, whether it is indirect or direct. If it is indirect with sample dilution, then electrolyte exclusion effect will come in. And that under circumstances where you have hyperproteinemia or hyperlipidemias, that 97%, 7% we have mentioned respectively for plasma water containing electrolytes and solutes will vary. And that the differences between the measured sodium can be up to 20%. And that is really serious. But then the CLIA, that is the Clinical Laboratory Improvement Amendment of the United States, has given some corrections or some ranges which could be conferred on, when assessing whether the changes in variability should be considered serious. For example, sodium, where you have a variation of up to 4 plus or minus 4 millimole per liter, that is acceptable. Chloride, acceptable. Of course, potassium at a very narrow range of 0.5 millimole per liter. That's acceptable. So it may not be necessary to raise unnecessary alarm under these conditions, having known that the electrode used may actually determine the variability across platforms. What about the matrix difference? Yes, we have mentioned it. Various analyzers have different ways they handle sample matrix, problem related to matrix. Some analyzers will use dialysis to remove the proteins or the lipids. So the technology that is inbuilt in that analyzer will determine how variable the results of these electrolytes will be across platforms. And we can usually look at other ones like calibration and reference methods used. Yeah, that is another a driver that can affect variability. So different vendors will have to use different methods or different calibration to check their traceability. So that will actually affect variability. And then sample type, as I've been mentioned, if there are serum samples or there are plasma samples, there are bound to be some variation. So the matrix effect I've been mentioned, where we have pseudohyponatremia occasioned by increase in lipids protein ratio, and that will interfere, and that will lead to different variation among platforms. Calibration drifts can occur within the instrument and leading to frequent recalibration. This is a challenge in auto-analyzer systems, and this can affect electrolyte results. And of course, these auto-analyzers are bulky. You cannot move them to other sites like intensive care units for critical care. They will remain in the central labs, and they are not ideal for point-of-care emergencies. Of course, cost and complexity. When it comes to technical maintenance, it requires maintenance engineers. When the analysts, where you troubleshoot and you are not able to get back to uptime of laboratory testing, of course, you have to call service. And that is very complex. Times you have to lead to long downtime. So I'm going to see. Next slide, please. So standalone ISC analyzers. We see some of these with very narrow testing menu. Sodium, potassium chloride, ionized calcium in most times. Some will give CO2 and some will give pH. This is a very narrow test module, so they cannot give us a complete metabolic panel, neither basic metabolic panel. So the sensitivity of these equipment is critical. The electrodes will foul, degrade, due to the coating of the electrodes by proteins, lipids, blood clots. And this causes it to question what have been mentioned before, sample handling. Highly etheric samples should be rejected, hemolyzed samples should be rejected, and of course, respinning of the samples may be in order to reduce exposure of these electrodes that can lead to degradation or outright damage or fouling of the membranes. And fouling of the membranes most times will lead to poor responses of these membranes, and that will affect the test results. Of course, it leads to drifts most of the times. Some of these standalone analyzers are prone to calibration burden. At times, they will fail quality control, and you need to calibrate and recalibrate. And you will notice that most times, some analysts have complained that these frequent calibrations, since they are closed systems in most cases, has led to depletion of the amount of tests, reagents that are programmed in those reagent packs. So this actually is a shortcoming. This electrical noise variability, other electrical noises can impinge on the readings of these analyzers and can actually shift the readings, can skew it. Therefore, this had to be contended with. The limited test menu, as we have mentioned, the comparability issues. because of some of these ISCs are built on point of cares, which has not been validated, and all manner of results may be obtained from different laboratories because of non-alignment with different modules, and this can become an issue and can at times affect the reputation of the laboratory. Then operational burden. Frequent troubleshooting is a problem because most times there is clogging of the peristaltic tubules, which will necessitate unclogging and then cleaning of the electrodes in most times. So this can take a lot of, you can imagine a very busy laboratory where you have batches upon batches of samples, and one will need to contend with this problem. It's really a challenge. Next slide. Next slide, please. So, yes, go back a bit. Go back. Okay, move forward. Okay, so we have, again, inter-analyzer variability for sodium results, as we have discussed across platforms. And where you have matrix effects, as we have discussed with auto-analyzers, that impinge on the results due to change in the matrix of the samples. And then calibration drifts, which are occur frequently and necessary calibration. And then dependency on central labs. And then you talk about cost complexity. I think we have mentioned this. Please, can you move to the next slide? Yes, we want to compare, place side by side auto analyzers at the standalone in terms of accuracy, speed, maintenance, interference, clinical use, and comparability. You are looking at auto analyzer modules. We talked about variation of results, especially sodium across platforms. This is a problem. But with the standalone, this may not be a problem because the electrodes measure directly the electrolyte concentration in the plasma phase, plasma part of the plasma water. So it is not dependent on electrolyte exclusion effect. So that may not be a problem with the direct electrode. But then the issues of calibration and then electrode wear. The salt bridges of the electrode can actually accumulate sodium chloride, which can affect its performance, and the electrolyte itself, as a result of fouling, can be compromised. And that will affect accuracy overall of the standalone analyzers. What about speed? Well, we know that analyzers have high throughput, but in terms of release of results, they are slower for urgent cases. So it may not be recommended for critical care, but for the point of care testing, as we see with the ISC inbuilt in them, is rapid, can have results at times in less than 2 minutes. Then maintenance, we have said it is complex, needing technical staff to do the maintenance. But for the standalone, well, the analyst can do that, but it has to do with frequent calibration. Analysts can equally learn to change the electrodes from time to time. Interference. Of course, here we have matrix effects. Interference here, as we might mention, can be as a result of physical interference with the electrodes when they are caused, as we have discussed before, by coating of electrodes by protein, lipids, or drugs, or blood clots. But it can be caused by ions, other competing ion in solution. For example, sodium can be affected by this interference when samples are taken from patients who are on manic preparations containing lithium. So this can compete with sodium and can interfere with the results obtained. Potassium itself could be interfered with by ammonium ions when samples are taken from patients with liver failure. These samples will contain high levels of ammonium ion. So these are some of the problems we can have with interferences. Now, clinical use. Central labs, we have said that standalone can even function as a point of care. So at various sites at critical care units. Then comparability. There is poor agreement for sodium. I've said that sodium is more affected than the other electrolytes. And then for the standalone, the results may not match with labs due to the proliferations of these point of cares that are not validated. and then they are used in various laboratories. Next slide, please. So what are the causes of downtime? Downtime associated with most common options. Downtime are those times that the analyzer will go out of function, whether it is planned, scheduled, or it came as an emergency, unanticipated. Auto analyzers or electrolyte module, calibration drift can actually cause increased downtime. As you calibrate often, the machine is going to be on standby. You cannot work. The downtime during these calibration cycles will actually increase. Clogging or contamination of the peristaltic tubules or the probe becomes a problem. Even the fluidics, if the fluidics are blocked, this will pose a problem and will require cleaning, flushing with enzyme solutions and the detergents as wash solutions. And this will increase the downtime of these analyzers. There could be mechanical failures. The robotic arms can fail. The pumps, peristaltic pumps can fail. The sensors can malfunction. All these things can prolong the downtime. The matrix interference, as I mentioned, can lead to repeat testing, and repeat testings will increase the turnaround time. Or if the troubleshooting fails, then the analyzer may need to be shut down in order for proper troubleshooting to be given, and this will affect the downtime. Scheduled maintenance. Scheduled maintenance may not be a problem in itself because it is scheduled. If it is scheduled, there will be alternatives. The turnaround times could be reconfigured. Samples could be sent to the site labs. Samples could even be sent out to other reference centers. Yes, if it is scheduled for maintenance. But when it is unanticipated, it becomes a real problem and it can affect the downtime. And that is where the laboratory is heavily concerned. The next slide. Standalone electrolyte analyzers. Does it have shortcomings? Yes, electrolyte degradation like fouling, replacement. If you check, some of the standalone electrodes now cost as much as 400,000 for one. And the replacement will equally add to the cost per test for patients. So this is actually a very big shortcoming. Frequent calibration, as I've said, then electrical noise and interference. So when you have other signals that are not signals from the ion of interest that are being measured, this is electrical noise. And this had to be troubleshooted. This can actually lead to increased downtime for these standalone analyzers. The membrane fouling, as I mentioned, this could be obviated if there is constant flushing of these membranes using the wash solution after each testing. This can actually ameliorate these problems and can lead to better performance of these membranes. And then potassium chloride crystallization, as we have mentioned, that can block tubings and can even damage the junctions of the reference electrodes. We have environmental sensitivity. Almost all the analyzers, including auto analyzers, will not operate at a normal temperature, the ambient temperatures of the laboratory. They need to operate under controlled conditions, air-conditioned temperatures. So, but most times you see the epileptic fire, power failures we have in our environment can be a problem. And you'll find in some centers where some of the ACs are not working and these analyzers are in operation with high humidity around the environment. And this will actually affect the performance of the electrodes. The accuracy of the electrolyte test is actually going to be affected. So as much as possible, these analyzers must be operated under clearly controlled temperature and humidity conditions. The peristaltic failure can occur, the pump can occur. This can actually affect aspiration of samples. And this actually will affect downtime in these analyzers. Those who have used it or who are using it will actually identify with these problems. The next slide. So summary and conclusions. So current approaches, they are robust. We must have to accept the performances overall are acceptable, reasonable acceptability, the performance. And these auto analyzers have the advantage of high throughput, But then the problem of variability around about other platform becomes a problem. For the standalone, the speed is an advantage, but maintenance burden that we add to cost becomes an impediment. Because of this, put together, every analyst, medical laboratory scientist, the pathologist, we want to see another generation of solutions for electrolyte testings that will be able to provide portable equipment that can be moved around to different sites in the laboratory, in the hospitals for testing. And these platforms will be standardized all across so that variabilities in results will totally or appreciably eliminated. And then the results will be highly reliable. Next. So what do we recommend? So looking ahead, one would want to have an analyzer that have improved metrics handling, irrespective of whether there is sample pre-dilution that can lead to electrolyte exclusion effect, that these problems will be adequately obviated by introducing correction algorithms, just as Nicholas K. Essiman equation have been applied in some analyzers to correct for some interferences. So this analyzer should have a dual channel to minimize interference from lipids and proteins, employing different methods of dialysis to separate some of these proteins so that the matrix effect could be adequately handled. Hybrid workflow integration. The analyzer should be able to pair point-of-care testing devices for speed and then enjoying the advantage of high throughput for the auto-analyzers so that both of them can work in synergy and can now improve the throughput. Now timeliness could be guaranteed. Then enhance electrolyte technology, miniaturization, and then technologically improved foul-resistant membranes in order to reduce fouling of these membranes and reduce the frequency of replacement of electrodes. If these technologies are integrated into these analyzers, that will be the analyzer of dream for the laboratory testing. Then automated calibration. Of course, we have some of these in our analyzers and standalones. They're able to do automated calibrations. But these automated calibrations should be able to obviate the problems. If it is a problem of clogging, at times automated calibrations may not be able to solve some of these problems. So there could be a need for manual calibration, recalibration of the machine. So next generation should be able to have analyzers that can self-calibrate with prompts at intervals when it is needed without the intervention of the analyst. And there's noise reduction. And this could be done by shielding and improved circuitry to reduce electrical interference. Most analyzers, if there are standby other equipment like MRI within the environment, centrifuges, this can increase noise. So this analyzer should be able to shield the analyzer's electrodes from the impact of these interferences coming from the environment. So we have mentioned the journey into today's technology for electrolyte testing, hinging so much on the advent of the electrodes. There are different forms, different modules and platforms, and then we have seen the need for improvement in these analyzers. Of course, some of these are already in place, but our host will be able to tell us whether, I don't know whether a few days ago, there have been rollout of a to solve some of these problems, as we are going to hear from them as they do the next presentation. Thank you very much for listening.
Thank you very much, MLS Jude Kamah, for that excellent presentation. We sincerely appreciate your time and expertise. Thank you very much, sir. So quickly moving on, we have our next and last speaker, Mr. Waheed, our Marketing and Application Manager, and he will be taking us on electrolyte testing, new thinking, new approach. So Mr. Waheed, you have just 15 minutes, please. Thank you very much.
Okay, thank you very much, Samuel. Can I be heard, please? So, my name is Waheed Nurudeen. So I'll be presenting to you on innovative electrolyte testing. There's a time for change. So, first of all, before I continue, I'm going to say a very big thank you to Dr. Lucius Imoh and MLS Kamah for the excellent presentation that they have given to us. I'm also going to start by introducing our organization for those that are not very familiar with us. We are Pinecrest Healthcare Limited, and we are an indigenous organization. We are partners with leading global manufacturers to deliver innovative and affordable healthcare solutions. Our mission is to provide quality and affordable healthcare solutions, and our vision is to be the most preferred solutions provider in every segment we play in and for every product or service that we offer. This is our contact. Now, talking about Exias E1 analyzer, I'm going to start by introducing the original manufacturer of Exias E1 analyzer, called Exias Medical GmbH. They are based in Austria, and they have a lot of experience in manufacturing electrolyte and blood gas analyzers, all the way from AVL Medical, when AVL used to be in Graz, until after Roche bought over AVL, and Exias E1 analyzer was launched in 2019 after Exias Medical was founded in 2014. Some staff from Roche and AVL are also the ones that are behind Exias E1 analyzer. So they have a lot of experience in manufacturing electrolyte analyzers. So now this is a slide showing us a summary of the features and benefits of Exias E1 analyzer. Number one, it's fastest on the market. It uses just 20 microliters of samples. It is also it uses an all-in-one cartridge that makes it maintenance free. Now, you ask cartridges that can meet your need if you run a lab or hospital that you have very high volume. If your volume is also not very much, this instrument can fit into your need. Also, has onboard QC, which is dependent on your choice. Let's talk about this instrument being maintenance free. The reason I want to start talking about the maintenance free feature of the instrument is because Mr. Kamah talked about maintenance problems with both standalone analyzers and chemical analyzers that have electrolyte module. Now, the benefit of having Exias E1 analyzer is, number one, it does not require any daily cleaning. There's no part of the instrument that you require to clean on a daily basis. There's no electrodes that you want to do conditioning for. You don't require flushing, of course, of the reference system, because it does not use potassium chloride reference solution like other electrolyte analyzers, other standalone electrolyte analyzers that we have in the market today. Now, it uses an all-in-one cartridge. All-in-one cartridge meaning that the sensors, the solutions, the waste, the reagents, all wear and tear parts, they are all embedded inside one cartridge. So you are not replacing calibrators, you're not replacing electrodes, The only thing you are replacing on one analyzer is the cartridge, because everything you need to run electrolytes is embedded inside the cartridge. So the instrument is truly maintenance free. Now, this slide is showing us what happens with some IC analyzers, and also some chemistry analyzers that have the electrolyte module. Now, most of these analyzers require deleting of the electrodes. They require daily conditioning of electrodes. They require weekly reference house cleaning. So you are required to change the probe wiper. You are required to change the peristaltic pump. You replace reference electrode. A lot of items or parts of these instruments need to be replaced from time to time. Now, and this takes about 75 hours, per year, to maintenance. But for E1 analyzer, all you need is just 5 minutes to replace the cartridge, that has everything you need to run the sample inside. It has the waste compartment is there, the calibrators are inside, even the controls can even be inside the cartridge if you want. So this instrument is truly maintenance free. Now, for an instrument that does not have any tube, that does not use the potassium chloride reference electrode, what do you need to maintain in such instruments? Nothing, seriously. Now, moving on, this instrument also uses the smallest sample volume in the market, just 20 microliters. And this is a huge advantage for pediatric patients. It's a huge advantage for patients that are in ICU and also in emergency rooms. Now, why is it very important for emergency rooms? It's important for emergency rooms and ICUs because you can also run samples, you run electrolytes on this instrument using whole blood. You can use whole blood, you can use serum, you can also use plasma and urine. So it's very important for ICU patients, pediatric patients. Another reason this is so important for pediatric patients is because it has multiple testing modes. You can collect samples in a capillary tube. You can collect samples in a sample bottle. You can even run samples directly from the syringe. So this is very important for ICU patients, for pediatric patients, and patients that are in the emergency room. So Exias analyzer has multiple testing modes, which saves you the stress of wanting to collect so many samples from a patient that is dehydrated. Looking at the measured parameters on E1 analyzer, it measures sodium, potassium, chloride, ionized calcium. Now, you remember during Dr. Lucius's presentation, he talked about how ionized calcium is a very important parameter in patient care. He talked about how most labs don't measure ionized calcium, how it is ignored. And it also talked about the high costs, of measuring ionized calcium on most analyzers. But on E1 analyzer, ionized calcium is measured. Ionized calcium is measured alongside other electrolytes. Aside ionized calcium, it also gives you hematocrit and also the pH. Now, the calculated parameters, okay, it also measures electrolytes in urine. You can measure sodium, potassium, chloride in undiluted urine, and you can see the measurement range here. During Dr. Lucius' presentation, he also mentioned measurement of electrolytes in urine, that it is really, really being looked over, that much attention is not paid towards measurement of electrolytes in urine, but Exias analyzer measures electrolytes in urine. Now, a measure electrolytes in urine, you don't require to buy a separate type of cartridge. The same cartridge that you use to measure electrolytes in whole blood, serum, plasma is the same cartridge you use to measure electrolytes in urine. Now, the calculated parameters, as you can see, it also has normalized calcium, it has total hemoglobin, it has also sodium, potassium, and chloride. It calculates 24 hours urine in sodium, potassium, and chloride. Now, let's talk a little bit about measurement of the ionized calcium. Now, it measures ionized calcium, and ionized calcium, like Dr. Lucius said, is a very important parameter to measure because it has, of course, much higher clinical value. Ionized calcium is about 47% or to 50% of total calcium in humans. And Dr. Lucius talked a lot about the importance of ionized calcium. Now, this is an analyzer that measures ionized calcium. It's not a calculated parameter on this analyzer. It is measured. Now, having E1 analyzer means you don't have to send samples abroad, because I've seen some labs that because they need a measured ionized calcium, they don't want an ionized calcium that is calculated. So some labs actually send their samples out of the country because they need a measured ionized calcium. Now, this is what we have on E1 analyzer alongside other electrolytes that it measures. Now, there's something also called normalized calcium. Now, normalized calcium is the ionized calcium corrected to a pH of 7.4 units. Now, because of the time it takes between sample collection and analysis, we discovered that the pH of those samples, increases with time. Now, that means the calcium you are getting at that point is not the actual calcium that it should have been if it was measured immediately when the pH was at 7.4. So what normalized calcium does here is that it calculates the ionized calcium using a pH of 7.4. So it gives you the actual calcium that is in the sample of that patient at the point of collection. So with the calculated parameter normalized calcium, the workflow related limitation that labs have is compensated by correcting the calcium to a normal pH value of 7.4. This is a clear advantage against other analyzers because most systems either do not measure pH and report calcium without pH correction. Some do not even measure ionized calcium at all. Now, what technology is behind all of this? How does it work? It uses a technology called thick film sensor technology. And what happens here is that the electrodes are miniaturized into a sensor spot. And that is why you see that it requires very minute sample volume and also very minute reagents. Now, these sensor spots are screen printed with precision on the substrate, and it forms the measuring cell. That's what it's called thick film sensor technology. Now, this instrument also uses direct ISC. Now, during Dr. Lucius' presentation, he talked about the issue of pseudohyponatremia that is affected by the indirect ISC that most of the autoanalyzers that have the electrolyte compartments use. Most of them use the indirect ISC, and indirect ISC can be affected by contamination of the process. But Exias analyzer uses direct ISC. So the issue of pseudohyponatremia is completely eliminated when E1 analyzer is being used for electrolyte testing. So now what we are looking at here in this slide is a comparison of the conventional system to Exias E1 analyzer. Most of the systems have the electrodes. They have flow through electrodes, which use approximately 110 microliters, and also uses potassium chloride as reference solution. Now, the cause of one of the major causes of downtime in electrolyte analyzers is the fact that the potassium chloride crystallizes in the tubes, it blocks the tubes, and because of that, tests cannot be run. Samples cannot be analyzed. But E1 analyzer does not use potassium chloride. It uses a gel-based reference solution. So it does not use potassium chloride. So because of that, the issue of potassium chloride crystallization is completely eliminated. This is one of the reasons we said this instrument is completely maintenance-free. Now, the electrolyte analyzer, like I said earlier, uses 20 microliters, and it includes temperature regulation. Inside the cartridge, the temperature is regulated. The liquid reference electrode is not a problem, it's completely eliminated. Now, that leads to the maintenance-free analyzer that we are talking about. Now, okay, I've talked about these slides. So, what are the benefits of this innovative thick film sensor technology? Number one, simplified logistics. You don't have to buy single electrodes. You don't have so many consumables to keep in stock. Now, the sample volume is just 20 microliters for 6 parameters. Now, the calibration solutions volume is reduced. Now, the calibrator is also part of the cartridge. So once you purchase an Exias E1 cartridge, it has the calibrators, it has the reagents, the waste compartment, and everything in the cartridge. Now, the time to result, just 25 seconds. You don't spend so much time trying to analyze the sample. The doctors have more time to manage patients. Now, the downtime is also reduced because, of course, the fact that it does not require any form of maintenance. So, Dr. Lucius also mentioned in his presentation that some electrolyte analyzers do not run bicarbonate, but Exias Imoh analyzer does bicarbonate. Talked about EQA compatibility. Mr. MLS Kamah also talked about some electrolyte analyzers not being compatible with external quality assurance. But E1 analyzer has proven over the past 4 or 5 years now that it is very compatible with EQA. Now, Dr. also talked about having some charts, the Levgenis charts. Now, E1 analyzer also has an LJ chart that can plot for you. You see how the instrument is performing against other analyzers when you use the EQA for the E1 analyzer. So, ladies and gentlemen, what is the point of bothering yourself so much about maintenance of analyzers, about purchasing calibrators, about purchasing reagents after you have purchased calibrators, when you have an analyzer that is completely maintenance free? If you want to have peace of mind in your laboratory when it comes to electrolyte testing, I recommend that you choose Exias E1 analyzer and choose peace of mind. So thank you very much for your time.
Thank you very much, Mr. Waheed, for that insightful presentation. We appreciate your time. So quickly moving on, we have the next item on our agenda won't be taking so much of our time, and it is sharing of user experience. And we have 3 scientists from 3 different facilities that will be sharing their experience with us making use of the E1 analyzer. So please, we have MLS Miriam Saizu from Chemical Pathology Department, Federal Teaching Hospital, Lokoja. We also have MLS Nezifi Adams Abdullahi from Chemical Pathology Unit, Aminu Kano Teaching Hospital. And lastly, we have MLS Chima Ugu, who is the laboratory manager at Seba Lancet, Nigeria, Victoria Island. So please, I don't know if you're in the house. Can you just signify or indicate, please? So, Mr. Chima, I got reactions from, I saw reactions from Mr. Chima, and if I'm not mistaken, MLS Nezefi. So, let's start with Mr. Chima, please. You are welcome on board, Mr. Chima. The floor is yours. So, if you can just share with us your experience so far making use of the Exias analyzer. So, Mr. Chima is from the laboratory manager at Seba Lancet, Nigeria. Mr. Chima, please unmute your mic.
All right. Good evening, everyone. Good evening, everyone.
Good evening, sir. We can hear you. Please, you have 2 minutes. We can hear you.
Okay. All right. Firstly, I have to apologize for not joining on time. And again, I was having network glitches even up till now. So that has made me to be going back and forth all through. So this evening I'll be sharing my experience with Exias E1 standalone electrolyte analyzer. I'll be sharing the benefits and some concerns I have regarding the POCT device. So I've used Exias electrolyte analyzer for 4 months. Yeah, 4 months. The analyzer came to us in February, and that was when it was installed. Then the performance has been good. It has an excellent precision, has a very good repeatability. The area that I like about the analyzer is the calibration. It calibrates itself. It prompts calibration every 30 minutes. It does the calibration. So This will also help to mitigate issues that arise from calibration. Unlike the Beckman, the auto chemistry analyzers, the ISC unit of the auto chemistry analyzers, that the user have to calibrate and recalibrate. At times, there used to be drifts, as mentioned by the presenters. Then I will also talk about the support from Pinecrest. So far, so good. Support has been great. Uh, we had a hands-on training on the day the instrument was installed. We had a hands-on training by all for all the end users of this instrument. The supply availability has been good. I've never had any issue of stock out. So I would also like to commend them on that area. Pinecrest have been doing very, very good on supplies of the cartridge. So they come at when due. So the only thing we need to do is the only thing I will advise is to remind them on time to place your order on time.
Thank you very much, Mr. Chima. I really appreciate the feedback from you. We really appreciate your time.
All right.
Thank you very much, sir.
So I will have to.
So moving on, please, I would also like to say this. We have an interest link for an interest form in the chat box. So if peradventure you are interested in probably procuring the E1 analyzer or having a demonstration, we having a demonstration at your end, please you can just quickly fill in the interest form and definitely a member of our team will reach out to you. So next scientist we'll be having is MLS Nezifi from Aminu Kano Teaching Hospital. Please, are you in the building? You can kindly unmute your mic and speak to us, please. Hello, sir.
Hello, are you with me?
Yeah, we are with you.
Okay.
So you have 2 minutes, sir. Thank you very much.
Okay, good afternoon, everyone. I appreciate this opportunity, and I've been following all the presentation. I'll start by thanking all the presenters for this wonderful and enlightening presentation. I'm MLS Nazif Adam Abdullahi from the Chemical Pathology Department at Medical Teaching Hospital. One of the QC officers of the department. Actually, this is almost 2 years or more than 2 years we are using Exias as our electrolyte analyzer. And with this instrument, we have solved most of our problems before that we are using the other ISC analyzers. For example, not only the volume of the sample that is very small and the time result. One of the most important things that I appreciate is, apart from the measured parameters, it does calculate bicarbonate too. And one of the most challenging parameter we are encountering in the electrolyte, and as you know, bicarbonate has everything separate chamber, and it has its own standard and controls. But using Exias, everything is inbuilt. You can just put your formula and the machine does the calculation. So this saves us of buying bicarbonate standard. Sensitivity of the bicarbonate chamber, you have to be cleaning it every day. As in our centers, we used to run more than 100 electrolyte samples a day. And this consumes a lot of consumables because now we have to buy the cleaning reagents and maintenance kits. So I want to talk of the maintenance free of the analyzers. We save a lot because we are not buying the maintenance kits. I'm talking of refilling solutions when you are talking with electrodes, and sodium adjust bicarbonate standard. And one good with it has onboard quality control. So it saves us another cost for buying quality materials, because if you are using another device, you have to buy different separate quality control liquids for you to be running for everyday controls. But using this machine, it does that completely automatically. So it saves and minimizes the cost. And you know, electrolytes, as you are using it, especially when you're dealing with huge number of samples, you have to deprotonize every day or at a time of or a certain number of samples. But using this device, we are not doing it. Saves us from that deprotonization every day and blockage of the tubes and precise tube and everything. So I actually recommend this. And in terms of supply, the pancreas, they are always there with us. A call, even if for maintenance or for instance, if we have any challenge, there is a person designated. Once we call him, within few time, will be here with us. And once we place the order, sometimes they even brought us the reagent without paying if we need it in an emergency case. As you know, electoral is always emergency. So I actually recommend the Exias E1 for the order because of these wonderful specifications and the maintenance free. And of course, you save a lot regarding the cost and the operation at all. Thank you.
Thank you very much, MLS Nazafi Adams. Really appreciate your time. And lastly, we'll be speaking with MLS Miriam Saidu, who is the head of unit Chem Parts Department at Federal Teaching Hospital, Lokoja. Please, ma, you have the floor.
Good afternoon, everyone.
Good afternoon, ma.
Can you hear me, please?
We can hear you loud and clear, ma.
Okay. First of all, I want to say thank you to Pinecrest Healthcare Limited. It's been wonderful doing business with you guys. The company has been very responsive. I would outline some of the issues that I had along the line and how swiftly those issues were attended to. But first of all, we have been using Exias electrolyte analyzer for, I think, more than 3 years now at our hospital. And since the coming in of that equipment, I would say that we have had no cause to regret getting that equipment. Exias electrolyte analyzer is one analyzer that I love so much. And because of the user-friendly that equipment is, we have also built bond with other equipment. There's several equipment that had come in for other tests in our hospital here. I want to talk about the key features. I like the fact that sample volume required for the Exias analyzer is very minimal compared to where we were coming from before. Just 20 microliter, that is wonderful because we can even use through capillary tubes, we can use them for pediatrics that we usually have challenges with collecting their blood sample. Another key feature is the results that you get, availability of the results in, let's say, about 25 seconds, thereabout, your result is out. And the fact that it is maintenance free, that is, everything is just in the cartridge. So beautiful. You don't have to come in contact with anything as the user. It does everything itself. It's just in one cartridge. It's a compact design suitable for point of care testing, which means we can have them by the side wards, ICU. In short, very important at all the key testing areas. Advantages, it's fast turnaround time, which helps in management of the patient. We have minimal maintenance. You know, you don't have to sign MOUs for equipment maintenance. It saves you all that stress. It has a high accuracy and precision, and most importantly, it is user-friendly. Very user-friendly. And I love the fact that it uses whole blood, it uses plasma, and it uses serum. So you can choose whichever one you want to make do with, which makes the work easier, very easy for us. I think by and large, we have enjoyed the equipment since it's coming to Federal Teaching Hospital, Lokoja. We started with the 150 by 150. From 150, we moved to 300, and now we are using the by 600. Our sample volume, it's between 40 to 60 in a day. That's our sample volume over here. We are still growing, and we pray we get to 100 or even more. By and large, honestly, I recommend Exias Electrolyte for any center that has not started using that. Yes, as regards the challenge, I know we had challenge with cartridge. Using the cartridge, and it gets to a particular point, it stops working. But I got to understand when I placed that complaint, I got to understand that it's possible it might be the batch of that particular cartridge. But by and large, it was replaced for us. Even when we had issue with the equipment, immediately it was another one was sent to replace the bad one. So I think Pinecrest is actually doing well, and the Exias electrolyte machine is a must-have and a sure-have for any facility that has not gotten. Thank you very much.
Thank you, MLS Miriam Said. We really appreciate your comments, ma'am. So the last segment of the event is question, comment, and answers. So already we've seen quite a number of questions in the chat box, and majority of them have been answered already by either our managing director or Mr. Waheed, who is our marketing and applications manager. So please, if by chance you have any further question, please just do well to drop them in the chat box so we can respond to them as quickly as possible. So that being said, we move on to the wrap-up comments by Dr. Chijioke Onyia, who is the managing director of Pinecrest Healthcare Limited. Dr. CJ, you have the floor, sir. Yeah.
Okay, thank you very much, our dear moderator, Samuel. This particular segment, which is the wrap-up segment, is primarily a bit of a recap of what has happened, and I want to sincerely start by thanking or recapping what has been presented to us today, starting from the presentation from our dear Dr. Lucius. Dr. Lucius took us through the journey of maximizing clinical utility of electrolyte testing, and he gave that particular topic the specialist attention that it required. I was so amazed, even myself, as the preponderance of opportunities and preponderance of tests and assessments that we can do for patients with the help of electrolyte testing. Some we're doing, some we are not doing. Dr. Lucius brought all of them to the limelight, talking about the issue of the hyper osmolar natremia, the anion gaps, both the HAGMA and the NAGMA, talked about the gap ratios, glucose to potassium ratios, urine sodium, talked about urine potassium, talked about urine sodium to potassium ratio, even talked about urine anion gap. He talked about fractionation, excretion of bicarbonates, talked about ionized calcium, talked about CSF in chloride use in cerebrospinal fluid measurements. He also talked about the quality issues that affect electrolyte assays, both the pre-analytical issues, the analytical issues, and also the post-analytical issues. Also wrapped it into with the quality management protocols, the internal quality controls and the external quality assurance protocols. Also talked about the suboptimal utilization of electrolyte markers in Nigeria. That actually hit me, and I'm sure it hit most of us that are sitting in this room. The suboptimal utilization, where we have so many things we can do with electrolyte testing, and so many of them are not being done. And he gave the reasons why this is not, we're not optimizing the opportunities associated with electrolyte testing, and also gave some recommendations in terms of the roadmaps you can use to be able to maximize these biomarkers in Nigeria. He wrapped up his presentation by giving us a fantastic case presentation from case 1 down to case 4. Dr. Lucius, God bless you for that fantastic presentation. Our dear MLS Kamah Jude also went to town to tell us the history and the genesis of electrolyte testing, okay, carrying us through the various technologies that actually were involved in the electrolyte testing, from flame photometry down to the ISC technologies. And he went further to now explain to us the difference between these approaches, the strengths and the weaknesses of each of the approaches. And he rounded up by putting it up for us to Pinecrest and the Exias to possibly share with us what they have in terms of their offering that may address some of the shortcomings identified. And that automatically keyed in Waheed into presenting to us the innovative electrolyte analyzer that really is a completely new approach and a new thinking to electrolyte testing that literally addresses most of the commonly encountered problems associated with the conventional IAC-based analyzers. He went to town to tell us the key features of this product and their benefits. But beyond telling us the key features, he even went to address the technology behind this innovative system, because it is at the heart of the technology that these key features and benefits actually spring up from. And also, we ended up this engagement with a sharing of a hands-on experience by MLSA Miriam Said. Thank you so much all the way from Lokoja. Nafiz Adams Abdullahi from Kano, and MLS Chimago from Several Answers. Thank you so much for bringing your unbiased perspective based on your hands-on experience and usage of this instrument. Some for a period of up to 3 years, some as few as 4 months ago in Several Answers. To be very candid, colleagues and ladies and gentlemen, all I want to say is that we've heard it all from all the participants. We've heard all the features and the benefits. We've heard all the perspectives with respect to electrolyte testing, because that's the theme. We weren't intending just to come and market our products. We wanted to bring in fresh perspectives and fresh insights into electrolyte testing. And I believe that we have been properly informed and educated. All I want to say is that for those who would want to partner with us, for those who want to have a taste and a feel of this analyzer, the door is wide open. We are open to placements. We are open to having the instrument purchased if you want. If you're a high volume user, you run up to 100 samples a day, Exias Analyzer is there to support you. If you're a low volume user, you run 3 samples a day, E1 Analyzer is also there to meet your needs across the various platforms. We can decide to work with you on a placement basis where you don't buy the instrument, you place it. We can also work with you with regards to staggered payments. If you are interested in buying and don't want to pay upfront in one swoop, we can work out with you a payments option. Bottom line is that we want to ensure that E1 Analyzer is in every lab that has to do electrolyte testing in Nigeria. And on that note, I want to thank you so much. There is a link in the chat box where you can fill up your interest, and we can now certainly follow up after this particular webinar. At this juncture, I want to hand over the mic to Sam to key in the last agenda item we have in our agenda. Thank you very much. Sam, over to you.
Yeah, thank you very much. Thank you very much, Dr. Chijioke. So to formally conclude today's event, we'll be inviting Mr. Ibem Emmanuel, who is the business unit manager at Pinecrest Healthcare Limited, to give us a vote of thanks. So, Mr. Emma, please unmute, and the floor is yours.
Thank you so much, Mr. Samuel. Good day, everyone. On behalf of Pinecrest Healthcare Limited and the Exias Medical Group, I sincerely thank our distinguished speakers, by the person of Dr. Lucius Imoh and MLS Kamah Jude, for their insightful presentation and valuable contribution, new thinking and also new approach. I also appreciate all our participants for joining us and for their active engagement throughout the section. A special thanks goes to the organizing team and technical staff for ensuring a successful event. Thank you all for your time, for the participation and commitment in advancing laboratory practice and patient care. Thank you.
Okay. Thank you very much, Mr. Emma. Ladies and gentlemen, that brings us... Okay. So, thank you, ladies and gentlemen. That brings us to the end of today's webinar. We also like to use this medium to appreciate Mrs. Tamara from Exias Medical. Thank you for taking out time to be with us today. So on behalf of Pinecrest Healthcare Limited and Exias Medical GmbH, I would like to sincerely thank all our speakers and participants for taking time to join us. And we trust that we've been able to contribute in terms of knowledge base to improving electrolyte testing and efficient patient care. So thank you once again for joining us. Then lastly, please, let's all ensure that we fill in the forms That's the forms for interest. So a colleague or a member of the team can actually reach out to us. So thank you very much once again, and have a pleasant evening. And we look forward to seeing you in our next webinar. Thank you very much.